Good morning again.
Good morning, doctor.
Morning, Doc.
Good
Uh,
morning, doctor.
uh, you decided to have this lesson online, so we will do it online. It's not a problem for me. I'm glad that most of your group is connected, and I hope that you read something for today's lesson. Today we're supposed to start with you the cycle of pediatric surgery, and this cycle includes 2 years, 5th and 6th years, students short cycles for 5 lessons, 5 topics each cycle in total. And fifth year, we'll talk about acquired pathologies. The 6th year, we'll talk about congenital malformations. So today, we'll start to talk with you about acquired pathologies. What about the portal? There is a couple videos as well there. And if you watch them, that will give you a benefit for understanding. Today is about the acute abdominal syndrome. And when I discuss with the acute abdominal syndrome topic, I prefer to start the discussion from the appendicitis topic in general. So the first thing that we will discuss is acute appendicitis in pediatrics, in children. About the children themselves, guys, what do you need to know? That basically they are not just small adults. They have their own features in everything. And you need to keep that in mind when we will do our discussion and our lessons during our cycle. What I mean, the biggest example is the fact that when we're talking about children, we define 3 different type of age of children. For example, the most adult ones we call teenagers. That's more above 12 years of age, like above 10, above 12 years of age. It's the basically adult people. You can talk with them, they can express themselves, they can explain what they feel, what they experienced. They can tell you their story, they can answer your direct questions, and they feel their own body with a clear kind of feelings. Toddlers, that's the second age. It's somewhere between 2-3 years of age and around 8-10 years of age. These children are young, they cannot express themselves completely fine as adults, even do not feel themselves the same as adults. Their neurological system is not mature enough to recognize the pain as the pain. And they, because of absence of life experience, cannot say for sure that what is discomfort and what is pain. So they can recognize everything as pain. And because of non-mature neurological system, you will discover that they cannot even specify the place of the pain. And the most youngest children are infants. They basically below 2 years of age, below 1 year of age. That's when the only thing that they can do is to scream and cry. That's the only thing that they can do and how they can express their feelings and thoughts. That's the most difficult age for us as doctors. And doesn't matter the age, they can develop acute appendicitis or other acute abdominal syndromes. It's not so common, but possible. So you need to keep that in mind. As well, as younger the body of a child, as softer their tissues and less barriers between the tissues. For example, serious example is when you have a phlegmon for adult, for example, a forearm, in the forearm. You will have a phlegmon from the wrist till the elbow, because that's the place of our main barriers between the regions of the body. And the main problem will stop at the level of the elbow. In children, this thing will spread really fast, instantly fast, and it will not stop at the elbow level. It will instantly grow above to the shoulder, to the body in a couple days. So because they don't have these barriers, intracellular walls, and generally protective mechanisms. As younger the child, as vulnerable they are. I hope you understood that. Okay, now guys, my lessons usually going as a discussion. So today I will do like a small lecture for you, mostly. But all other lessons, I expect you to do the lecture for me. That will be our lessons goes. And my request is when you're answering, it's better to turn on your microphone and the camera at the same time. About appendicitis. My first question to you guys, what is acute appendicitis? Who can answer?
Inflammation of the appendix.
Pretty much simple, right? Appendix and itis, that means inflammation. Inflammation of the appendix. What kind of appendix?
The vermiform appendix?
The veriform appendix, the one that's going from the intestine, right? Because we have another appendages in different parts and organs of our body, where this appendix is usually localized.
Retrocecal?
No. Retrocecal is the position of the appendix itself. I mean, like, where does it go from? What's the part of an intestine that it's attached to?
Ascending colon.
Ascending colon, almost correct, but there is one more short colon that is before the ascended one.
The cecum?
Cecum.
Cecum, right. So if we will draw the schematical picture of the appendix localization, we will have something like that. And over here, we have our appendix. That's our appendix. The cecum, the ascended part, the liver angle, transverse part, spleen angle, distant part, sigmoid, rectum. And then anal canal at the bottom. Okay, and if we're talking about the quadrants of the body, in which quadrant that will be?
Right lower quadrant.
Right lower quadrant. Okay, another name for right lower quadrant.
Right iliac fossa?
Right iliac region.
Region, right iliac fossa, correctly. Completely correctly, guys. Good. But keep in mind, I told you that it's average position of the appendix and average its localization. Sometimes, by unknown reasons, can develop congenital malformations of the intestine, and the intestine can stop its growing over here, for example, and the appendix will be here. The person can still develop appendicitis, but in this case, the pain and everything will appear in another region. It also can happen. It's rare, but possible. Again, if we're talking about appendicitis itself, inflammation of the appendix, you must understand that the book describing the clinical picture of only for the most common localization of appendix, like I draw this the standard one. But you must understand that it can be localized in different ways, even if it's still in the right iliac fossa. It can develop different kind of clinical picture depending on its own localization. That's why the old surgeons told about the appendicitis that it's monkey of surgery, because it can mimic other clinical pictures of acute abdominal syndrome, so other regions. For example, giving you an example, if the appendix is localized antegrade like that, it's laying down on the ascending colon, it can be really long. It can go and touch the gallbladder of the liver, because over here we have the liver. And if that happens, the person will develop clinical picture of acute cholecystitis, and you will not be able to differentiate that from acute appendicitis. It will give you clear picture of acute cholecystitis. Another example, if it's localized retrocecal, for example, it's growing like that, and it's localized behind the cecum. In this case, most of the symptoms will be absent and only slight pain in the right iliac fossa will be present. Another thing, it can be localized more longer to the pelvis and mimic the cystitis, for example, inflammation of the urinary bladder. Sometimes it can touch the ovaries in girls and mimic the inflammation of the ovaries or the uterus. If it will localize to the center, like that, for example, it can be really long and touch the pancreatic gland and mimic acute pancreatitis. And all the lab tests, all your diagnostic will give you acute pancreatitis. Another example, it's retrocecal retroperitoneal localization. It's when the appendix localized and grows behind the cecum, but it enters in the retroperitoneal space and going or like that, doesn't matter. And it goes to the kidney, mimicking pyelonephritis. And all your diagnostic will give you pyelonephritis. So for that, all surgeons told like the most difficult and the easiest one is acute appendicitis at the same time. That's associated with the inflammation. But what actually caused the inflammation?
Obstruction.
Obstruction, one of the most popular theories that counts as the real reason, but it's not completely 100% cases. Just it's one of the most common. When the feces enters the cecum, sometimes that happens that the child, adult, doesn't matter who, ate a lot of solid foods and heavy ones. They can fall down into the cecum and will not be able to get it out. And sometimes it even trap into the appendix, because inside of the appendix we have a small duct. It's not always there, but most of the times. And blocking the passage and stuck there. The intestine have the muscles to move, to cause peristaltics, but appendix do not. So if the feces trapped is there, that will cause a problem definitely. The result of presence the fecal masses in the appendix, because in the blocking, the bacteria that stocked there start to multiply, the object itself start to compress the surrounding tissues and causing the appendicitis, inflammation of the appendix. What other reasons, guys, do you know?
Infection.
Infection, so also bacterial etiology. In this case, you can talk about dysbacteriosis. Another kind of theory that severe dysbacteriosis can cause appendicitis as well.
IBS or trauma.
Irritable bowel syndrome. Unfortunately, I can't agree with that because mostly the syndrome associated with the distal region of the colon, not the proximal one. But
Oh, okay.
But the second one that you told is trauma, and it's actually true. Trauma can in the abdomen can cause the edema of the tissue that can lead to appendicitis as well. That's correct. Also, radiation can cause it, and tumors in the region as well can cause appendicitis to develop. Okay, that's the most common, but let's attach the most common reason, obturation theory. Pathogenesis, how this thing develops. How many stages do we have in the development of appendicitis? Who remembers?
Are there 3 types or 3 stages?
Nice.
The simple, is it the phlegmonous and the gangrenous?
Catarrhal.
Simple or catarrhal
catarrhal, phlegmonous, and gangrenous.
I don't know how to write catarrhal in English, guys. Sorry, so I will write like that. Catarrhal, simple. Catarrhal. Then we have simple. We have infiltrative. And we have serous inflammation. That is the first thing. Doesn't matter how you will name. The main thing about that is the fact that it doesn't cause pus. It doesn't bring pus yet. The inflammation already started, but there is no purulent contents yet there. Second stage, as you said, is phlegmonous. Phlegmonous, what means bringing phlegmone. And that means that this stage you have accumulation of pus in the side of the appendix and inside of the layers of the appendix itself. Bringing what? Inflammation itself causing the edema blocking the blood supply, making it not adequate, the blood supply. Problems with blood supply brings ischemia, making the pain and the problem even worse. The bacteria is multiplying, starts the accumulation of the pus because of the reaction of the immune system. In total, the amount of edema and pressure on the vessels and capillaries increasing even more, making the case even more, leading to the third stage that has name gangrene. Gangrenous stage, bringing gangrene. But in total, they're together some books define as destructive. As destructive appendicitis. I do not like the way when the book's saying that it's only two stages, like catarrhal and destructive, or simple and destructive. I prefer third one because it's more detailized and have fixation with the histological examination. As well, you need to remember that each of them averagely 1 equals 2 equals 3 stages and equals 24 hours. So in total, we have 3 days for appendicitis, averagely, guys. Sometimes it can be really fulminant form when we have gangrenous stage in the first day, and sometimes it can take 4 days to develop. But if it's more than 4 days, that's definitely not appendicitis. Because otherwise, what will happen after gangrenous stage, guys? What complication it will bring?
Perforation.
Yeah, perforation.
Perforation, good, and all the pus and contents will go into the abdomen, leading to
Peritonitis.
peritonitis, right, guys? And in this case, peritonitis, you need to remember that that thing is deadly. This thing can cause death in around 15–20% of cases. So each 5th, 7th person can die during the development of peritonitis clinical picture. Not directly, it doesn't mean that peritonitis means death. No, it has some steps. You can break all of them during the process of going to die. But if the person will not get medical attention as soon as possible, he will definitely die soon. So that's why this disease is the most important one, according to our problems. The clinical picture of acute appendicitis. In this case, guys, for you to understand, you can explain any kind of clinical picture in any disease that ends with itis if you think about that in a correct way. What do I mean? Tell me, guys, who remembers 5 local signs of inflammation? Redness, fever,
Loss of function,
loss of function,
Pain.
edema.
Swelling and edema is the same thing. Pain.
Okay.
Pain.
Yeah.
And the last one?
Is it color or redness?
Yeah,
It
color
was
of
the
that,
first.
yeah.
It was the first that you named?
Loss of function, pain.
Loss of function. Or you told about that?
Yeah, I can't remember.
Let's remember, let's again. Redness, swelling, pain,
Yes.
local
Pain,
temperature, and loss of
loss
function.
of function.
Yeah, so 5 signs of inflammation, local signs. But they are not just local, actually, guys. They are present in any part of the body that referred with inflammation. They are common for doesn't matter what. If you know the localization of the problem and the function of the thing that's inflamed, you will be able to explain clinical picture extremely easily, even without reading the materials and getting ready for the lectures. How? For example, redness. When we referring to redness, what do we actually mean? What happens with the skin when it's becoming red?
Increase blood flow to the place.
Right, basically
Arterial hyperemia.
right, we have hyperemia, we have increased capillary and arterial blood flow in the region to stimulate the process of protection for the body. It's the compensatory mechanisms for any kind of disturbance. So what do we have as a result? So in any place of that is inflamed, we can have redness, but some of them are superficial and they can be visible. Some of them, like in case of appendicitis, is too deep inside of the body, like it's inside of the abdomen. It's incredibly deep in several amount of layers. That's why on the skin, it will not be noticeable redness. But if you will turn on ultrasound, apply the sensor on the skin, and with the skin and ultrasound with a Doppler effect, that's the effect of the ultrasound that shows you the blood flow, you will be able to notice that actually the blood flow of the appendix is increased a lot according to surrounding tissues. If you're lucky and you managed to find the appendix with an ultrasound. We'll talk about it when we'll talk about that diagnostic. Second thing, swelling, edema. Doesn't matter where that happens, inflammation brings swelling. But when we're talking about internal tissues, the swelling, accumulation of the fluid in between the cells and between the tissues is not just local, it's also evaporating in surrounding tissues. What do I mean? I think you have the experience when you're taking the glass bottle from a fridge and putting it on a table and it's starting to be covered with a dew, some kind of dew, right, guys?
Yes.
Yes.
Yeah, the same thing happens in case of inflammation inside of our body. An appendix during inflammation start to evaporate the liquish part of the blood outside. So it's accumulating inside of the abdominal cavity as a free fluid, and that can be noticeable by ultrasound. By the way, again, if you're lucky and you manage to see the appendix by the ultrasound and you measure its size, it will be swelled, definitely. So we have swelling. Next one, pain. I think everybody knows that the first and the main syndrome of appendicitis is pain, right? So it is present. Now we have temperature. Trust me, if you will take a thermometer and your appendix is localized classical place and you measure the temperature of the abdomen in that area, it will be slightly higher than all other temperature of the body. But if no, then no. If the appendix is in a different position, you will not notice that. But our body in this case reacting with a general fever, and that also can be counted as temperature symptom. And the last one, loss of function. We do not know what's function the appendix itself. There is a couple theories about that. By the way, guys, what is the theories about what's the function of the appendix? Why the hell do we need it?
They said it's for digest. It has some bacteria that digest materials in the body, and they said it's the more before it's always big, but now it's becoming smaller. I don't know.
Actually, the size stays the same of the appendix itself, depending on the age of a person and the size of the body itself, and it's completely individual. Some person can have a really small abdomen, but the size of the appendix will be huge, and in opposite it can be completely different. The size of a person can be huge, but the appendix will be small. About the digestion, there is a theory that appendix is actually a storage of the bacteria in case of severe dysbacteriosis to restore its normal amount of and balance of the bacteria inside. Just one of the theories. Who knows other theories?
It says it's like a lymphoid organ.
Come again?
Lymphoid organ that it
Correctly.
stores like antibodies.
Correctly, that's another region because the histologically appendix is mostly lymphoid tissues that people thinking that that is actually referred to immune system, and they call it as immune system of the intestine. Good theory, nice. There is another kind of theory that actually the appendix is taking part in the blood differentiation of beta cells of the blood, because generally we know we have only young ones in the bone marrow and we have the adult ones in the periphery blood, but we don't have the intermediate ones or when they are differentiated in the body. Nobody found that. And some people proposed that probably it could be happening in the appendix. Other people saying that it's just a rudiment left from the ancient times during evolution, so we actually don't need it. So the theories are a lot, but clear answer is absent as always. But when I'm talking about function, in this case, from this point of view, it's attached to the intestine. So as a fifth symptom, loss of function, you will have absence of proper peristaltics, absence of proper function of the intestine. And that refers to a proper clinical picture. By the way, guys, to remember these 5 signs of inflammation, it's easier to remember in Latin. Who remembers the names for these 5 signs of inflammation in Latin?
Rubor, color, and dollar.
Color.
Pallor, right? And functio lesa, correctly. But you can say it a lot easier. Color, dolor, tumor, rubor, functio lesa. Color, dolor, tumor, rubor, functio lesa. A lot easier to remember in this order. Okay, now let's talk about the clinical picture itself. We already tried to describe it from fifth point of view, and we basically managed that, but I want to hear your clear understanding, so let's talk about the clinical picture. What kind of complaints the person will have if you have appendicitis? Imagine yourself a teenager, adult person, more adult, like around 16 years or 17, that have appendicitis. What kind of complaints he will have?
There will be pain in his right lower quadrant.
Initially pain and right lower quadrant, correctly.
Fever.
Fever, yes.
Fever, right.
Vomiting.
Vomiting, correctly. Usually single or double.
Sometimes there might be guarding, that is hardening of the abdominal muscles.
Correctly, but that will not be his complaint. It's not the clinical picture, it's diagnostic term.
Yeah.
We'll talk about our physical examination in a second. Let's focus on the clinical picture that he will tell to us, that he will describe by his own words. So,
difficulty walking.
Yeah.
The patient might have some difficulty walking also because of movement.
Again, that's for diagnostic.
Okay.
One more thing, guys, constipation. And another thing that is pretty common for appendicitis, that's one of the positive signs for appendicitis included in anamnesis when you're interviewing the patient, it's the way how the pain appears in the body. It's called Kocher sign or Kocher symptom. It means, guys, that the pain in case of appendicitis is supposed to start in the epigastric region. or paraumbilical, but in upper paraumbilical region. And from this place, in a couple hours, it will shift to the right lower quadrant with time. That's why people usually ignoring this pain in the beginning. Initially, they thinking like, I ate something wrong, that's why it has like slight pain. Then in a couple hours, it's moving to the right lower quadrant. So the person, it's moving down, so soon I'll go to toilet and everything will be fine, the pain will be gone. But the pain doesn't go nowhere. It aggravates, making worse. The person starts to develop fever. The person starts to have a problem in going toilet because of, like I said, absence of function of the intestine. And if in our body everything is working by one rule, if something cannot go in the correct way, it will go backwards. So because of the intoxication in case of the inflammation of appendix and absence of proper function of the intestine, the person will vomit. And at that moment, usually people realize that actually this thing will not pass by itself. I need to go and visit the doctor. That's why in their clinical picture, they have only 1 or 2 cases of vomiting.
Doctor, I have a question.
Yes, please.
Basically, so if they have the pain starting in the middle, it hasn't spread to the right side. If you were to like put pressure on the right side at that point, would they feel pain?
Yeah, and that's one of the signs of diagnostic that we will talk in a moment.
Okay.
So that's our clinical picture. That's the story that the person will tell to you when he enters in your office, when you admitting the patient in the admitting department. Next, you need to do physical examination, right? You already, by his story, suspect acute appendicitis. Actually, guys, if the person has a complaint about the abdomen, top number 1 in your differential diagnostics supposed to be acute appendicitis. It's your goal is to rule it out as number 1. So you're doing your physical examination. Not to mistake, I always tell to the students that you need to follow the rules of 4 steps of physical examination: observation, palpation, percussion, auscultation. Actually, in our case of abdominal problems, better to do auscultation before palpation. But I don't want to make you confused, that's why we'll not stuck on this rule. Observation. That's the place, that's the thing that starts when the person entering your office or entering the hospital. And that's what Samuel said. That is, when he enters the room, you start to observe his behavior. And you notice that when he's walking, he is guarding his abdomen. Normal person is walking like that without any problems. But affected with appendicitis, they glide upon the surface. They carefully carrying their abdomen not to shake it, because any kind of movement in the abdomen causing pain. That's the thing that you will notice by your observation. As well, if you will ask him to sit or lay down, people with appendicitis will prefer, some of them prefer to sit, but in a crunch position. They will guard the abdomen like that. Like not just like that, but bend it towards. Or they will lay down on the right side of their body with the knees closer to the chest, in something between average position in the side and embryonic position. So that's the places, the positions of the body that's decreasing the pain, and that's why the people taking this position while they're sitting or laying down. Another thing that you need to do while you're doing the examination, you need to remove the cloth from his abdomen. And at that moment, you can notice one more thing, that the person, while he's breathing, he's sparing this abdomen in the act of breathing. For you to remember, we have 2 types of breathing, actually 3. It's chest kind of, that's more relevant to girls, abdominal type, more relevant to guys, and mixed one, both at the same time. Now you're controlling your breathing, so you will not realize which type do you have. But in this case, you will notice, you're supposed to notice, that the person breathing only with the chest, sparing the abdomen in the act of breathing. At that point, that's mostly the most important things that you can observe. Next step is palpation, and that's the most important thing that you need to do during your physical examination, because that will define your diagnosis. If you open Wikipedia, you will notice that there is more than 20, more than 30 different signs for appendicitis, and almost all of them relevant to palpation, except one of them. It's called Gumberger sign. Gumberger sign is an official name for the sign that's saying that you need to propose a Gumberger to a person. And if he will agree to eat it, that means that he do not have appendicitis. If he refuse, that means that he do have appendicitis. It's relevant to anorexia, absence of desire to eat food during appendicitis, during malfunction of the intestine, and during nausea. So in this case, there will be complete absence of desire to eat food. And why Gumberger? Because from the logic of the outer, everybody loves Gumbergers. In children, not always this thing working, so I usually ask what's their favorite food, and then I'll ask about would they eat it right now or no. When I was an intern, my mentor, he always asked this question. During a regular checkup, during all other necessary methods of examination, he included this question as one of the final kind of questions. And imagine yourself a picture, the person laying down, he's doing ultrasound, and during the ultrasound examination, he's asking him a question. If I'll have a Gumberger, will you eat it or no, if I'll propose it to you? And if the person says, yes, I would eat the Gumberger, he is telling like, no, you don't have appendicitis, that's your prescription what to do, go home, relax, and everything will be fine. But if you refuse, he's calling to the operation room and saying, get ready, we will have appendicitis case. And he actually never mistaked. Okay, so palpation. As already you guys said about the fact that the pain will be localized in the right lower quadrant, so palpation in that region will be painful, and that's a positive sign for appendicitis. As well, while you palpating there, you're not just supposed to cause pain to the person. No, it's better for you to feel with your fingers what exactly is there. And with the feeling, you're supposed to feel a tubular shaped object. The palpation of this object is supposed to be most painful. Then it defines the epicenter of the pain, and usually if it's in the right lower quadrant and near the cecum, that's appendix, that's inflamed. Okay, what other palpation symptoms do you know, guys?
That positive psoas sign. Sometimes they call it Popratsovard, sometimes call it Kopp's psoas. There is also Rovsin sign as well.
But wait a second. I want to clarify that for you. You ask the person to lay down, and when he's laying down, there is two ways how you can actually check this sign. I will explain you the most easiest one. And you're asking him to lift his right leg upwards. He is lifting his right leg upwards, and during this movement, he is actively moving it upwards, and you can even block his movement. You can put your hand, not allowing you to do this. He intensing the muscles that's localized over here in this region. It intense iliopsoas muscle. And if the appendix in classic position and touching this muscle involving the muscle in the process of inflammation, this movement brings pain in the right lower quadrant of the abdomen. If he tries to lift his right leg in a straight way, like flex it, and feels pain in the abdomen, that's positive psoas sign, positive for appendicitis.
Rovsin sign.
Rovsin sign. Okay. What is Robson?
Robson sign is when you deeply palpate the abdomen, the patient might tell you that they feel pain in the region below or just below the area that you palpated.
I think the pain will be when we release our arm. We push, and when we release, then he will feel suddenly pain. Patient will.
That has a name of Bloomberg sign that you say. Robson sign is actually another. Palpation in a left area, for example, will give you the pain in a right one, in a right area. Another symptom that was named by Hitesh is Bloomberg sign. When you pressing in some area of the abdomen, actually there is two of them. One, you're pressing in the right lower quadrant in the area of the pain, but you're pressing gently but deeply. And then you really fastly move your hand out. You're pressing deeply and softly, and then fastly release your hand. This movement, this maneuver, when you're pressing the hand in and then fastly relieve, brings the intestine firstly to move around your hand, to bypass your hand, and then instantly get back to the normal position. And this fast movement brings flash of pain, bring incredibly strong and flash of pain. You will notice that even if the person tried to hide it, pupil dilations, facial expression, the person can even scream sometimes. Other symptoms.
Can we use the obturator sign?
Obturator sign, do you explain?
Okay, you let the patient to lie on his back.
Yeah.
Then you hold the knee with like in a 90-degree angle and rotate the hip by moving the ankle of the patient inwards. Yes, in an inward, yes.
Okay.
And then it will give pain in the
right lower quadrant.
In the pelvic. Is it the pelvic region?
In the pelvic region or the right lower abdomen region on this one.
Yes.
I will tell you, not always the sign is positive.
Yes, it's not always where it will be positive for appendicitis. It is used with other signs, like the source sign. Yes.
Yes. So if the appendix involving in the process the structures near the obturator is definitely the sign positive. Definitely will give the sign positive. So obturator sign.
I don't remember the name of the symptom, but we will say to the patient to turn on the left side.
To turn on his left side of the body. Right.
Yeah.
In this case, like I said, he preferred to lay down on the right side, but if you're asking him to lay down on the left side, the pain could aggravate in the right lower quadrant because of the shifting of the organs in the contralateral side. Correctly.
Exactly.
What else? You can check a T-short sign, for example. You're taking the cloth of a person, stretching it towards. Mine is black, so you can see what I'm doing. And you're basically doing this move. You're shaking, you're doing the wave-like motion from the top to the bottom of his body, like that.
Yep.
Not really deep, just superficial. You're doing fast wave of his subcutaneous tissues down with your hand. This movement brings pain in the right lower quadrant in case of the inflammation of the appendix. You're shaking the area of the abdomen. You can do cough sign. You can ask person to cough. In this case, when the person is coughing, he's intensing his diaphragm and the core muscles, the abdominal muscles, and the diaphragm pushing at the abdominal organs by itself. And if there is inflammation, it will be painful. So coughing will be painful, and the pain will be localized in right lower quadrant. That is positive for appendicitis. You can ask the person to jump. You can ask the person whatever you want. Any shaking of the abdomen will give you pain in the right lower quadrant in case of appendicitis. You can do the fluctuation sign. You remember how you're applying the pressure, like movement from one side and holding your hand in another side to listen and feel to the wave that comes. You're doing wave-like movements of the internal tissues, and that gives you pain in the right lower quadrant. You can do whatever you want with the patient in a normal manner, I mean, guys. In the sense of shaking the internal tissues causing movement in the area of appendix. And that brings pain. That means that's positive for appendicitis. Okay, rectal examination, the one that mentioned by Hakim. In this case, when you're doing a rectal examination, you tilt and move the rectum to the left and to the right. Usually, this movement is painless. It's not even a discomfort. It's strange feeling to the people who are adult and can able to explain that, but maximum what they feel is discomfort. If there is appendicitis and the process involving the rectum or the intestine nearby and the tissues nearby, if the process is severe, movement in one or another direction brings pain. And even sometimes, guys, if you're lucky, you'll be able to palpate the inflamed appendix through the rectal wall, if its localization is close to rectum. Usually, guys, when I'm checking the child with suspected acute appendicitis, I'm checking from 5 to 10 different signs for me to understand the case, because it's only on the books it's so clear. In real life, it's not clear at all. And you're basically counting the amount of pluses and minuses in front of each sign and symptom that you know, that you remember, and by the total amount of pluses or minuses, you can definitely say that it's appendix or appendicitis or not. There is no other way. So you definitely need to know as many symptoms for appendicitis as possible. Okay, guys, nobody said that also there will be present a muscular guarding, muscular rigidity sign, or another name in Latin, musculus defens. Especially it will be really, really noticeable in the right lower quadrant. What does it mean? While you're palpating, the person intense his muscles that breaks your possibility to do deep palpation. It does your hand.
Oh, you mean guarding?
Yes, like I said, abdominal guarding, musculus defens, or other kind of that. I think that was the thing that Samuel said in the beginning, right? Because he said the guarding, I referred that to the way how the person walks, but maybe you meant that thing. In this case, you literally cannot do deep palpation because the person intensing the muscles. And even if you're asking them to relax, they cannot because it's reflex. It's not conscionable. They're not controlling that. That is the picture that the person have during your physical examination. Another signs that you can use is actually anything that you can use with a shaking or movement. And believe me, all of them, all that you will figure it out, have its own name fixed somewhere by someone already. Giving you an example, you can ask the person to dance. He will feel pain in right lower quadrant. Any shaking in the area will give you pain that could be relevant to acute appendicitis. And the pain is supposed to appear in the area of appendix. That for the symptom to be counted as positive for appendicitis. At that point, we finished with palpation. Next step is percussion. When you're striking upon the abdomen. What sound you will hear in the abdomen in case of percussion with acute appendicitis?
Dull sound?
Dull?
Dull where?
In the right lower quadrant.
In the right lower quadrant and in the flanks as well from time to time, if there is a huge amount of accumulation of fluid and a serious edema. True. And all other abdomen will give you what sound?
Tympanic?
Tympanic.
Tympanic sound, correct. And the last one that I told you is auscultation. What you will hear if you put your phonoendoscope or stethoscope upon the abdomen to hear for peristaltics?
You hear reduced vowel sounds in that area.
Reduced vowel sounds, correct. In this case, we already talked about that, just you confirming this with your auscultation correctly. This combination of signs and symptoms allow you to put a diagnosis of acute appendicitis. If you doubt and you do not have a lot of positive signs, but you still have some of them, you need to prove that. You need to prove the presence of acute appendicitis.
Blood
To
test.
start with blood, and blood will give you with leukocytosis.
Okay, so you're doing complete blood count correctly, and that will give you some specific signs like white blood cells count increased, leukocytosis. What else? Information about
You
Ultrasound.
do also ultrasound,
ultrasound. Okay,
and it will show you an inflamed appendicite, and it will show
inflamed
you,
appendix.
yeah, appendix. Yeah, it will show you the localization also, so you can decide how you enter the abdomen.
I disagree with you in this case because ultrasound in this case, in case of appendicitis, is useful only in 20% of cases, like 1 to 5. From my own experience, can tell you that it's even less than 1 to 5, because it's not always possible to visualize the appendix itself with an ultrasound, and that doesn't give you the information about the appendix, but you can use it to find what? I mentioned that in the beginning of the lesson. Free fluid. If you're visualizing free fluid in the right lower right iliac fossa, or a huge amount of fluid in pelvis, that could be relevant to appendicitis. Let's get back to the blood count because we definitely that is the most important thing for appendicitis, to do the diagnostic. Complete blood count, simple blood test. There is 4 signs that you need to remember that is relevant for purulent infections. Who can tell them? One of them, Samuel Zombo mentioned about white blood cell count increased, leukocytosis. Right, 3 more left. What else there will be?
Increase C-reactive protein.
C-reactive protein is not included in complete blood count. It is a part of biochemistry tests, but yes, it will be inflamed. For me, I do not ask the laboratory to do C-reactive protein because, well, that's useless for me. I definitely know that the person will have information if he will have the specific info in the complete blood count.
Increased neutrophils?
Nitrophilic shift from the white blood cells, correctly. And especially, guys, focus your attention that stop core neutrophils will be increased as well, young ones. So in some books you can find the phrase shifting of the Leyko formula to the left. That means that nitrophilic shift, increase the amount of neutrophils. That's the same, all of them are synonyms. That's 2.
Yes, sir.
ESR, what happened with ESR and what is it?
Erythrocyte sedimentation rate.
Right.
And they are basically increasing inflammation.
Correctly. Any kind of inflammation, any kind of intoxication in the body, increasing ESR, erythrocyte sedimentation rate. Correctly. And one last thing.
Increased lymphocytes.
Decreased.
Decreased lymphocytes. Okay.
Decreased lymphocytes, right? Because lymphocytes and neutrophils and white blood cells, they are like balance. And if neutrophils goes high, lymphocytes goes down because the formula counts in 100%, represented as 100%. And if the percentage of neutrophils goes high, lymphocytes goes down. These 4 signs of in the complete blood count showing you purulent activity in the body. And with the clinical picture that you have with the patient, you can say that he have acute appendicitis. That is not a mistake if you will do urinalysis. If you will do urinalysis, it will not be a mistake if you do biochemistry of the blood to check the enzymes for the liver, for the kidneys, for the pancreatic glands and other kind of markers of functions of other organs. It will not be a mistake if you'll do an X-ray of the abdomen, because they do not have a possibility to put the diagnosis and confirm the diagnosis of acute appendicitis, but they will help in differential diagnostic. They can rule out other acute pathologies. So sometimes you can do like that. But CT scan and MRI is counted as hyperdiagnostic, too much, unnecessary. In some cases, when you already did a lot of things and you cannot 100% sure say that it's one or another, you can use them. But in our country, for example, we have an order that's saying that we have or 2 or 3 hours for adults and around 6 hours for children to put or rule out acute appendicitis diagnosis. It means that in a term of 3 hours for adults or 6 hours for children, you do not manage to rule out acute appendicitis. You're supposed to do the surgery, because it's better to do the surgery than mistake. And during your surgery, you will definitely confirm or rule it out. So for example, we have confirmation of acute appendicitis. What kind of surgery we need to do, what's the name, and what's the technique?
Laparoscopy.
Okay, we have 3 kind of assays that you can do. Laparoscopy is just one of them, how we can enter the abdomen. Laparoscopy means that we're using a camera and manipulators. Laparo, abdomen, scopy, observation. Look into the abdomen. Okay, that's number 1, golden standard worldwide for this operation. What's other 2 methods?
Laparotomy.
Laparotomy, right, laparoabdomen, tomy, incision, cut through the abdomen. So you opening with the abdomen with a blade, bringing the appendix out and operating it through the incision. That's old-fashioned, but still works, and using as a plan B if laparoscopy failed. Actually, a third one is not written in the books. It's counted as modern and extremely complicated. It's endoscopical surgery. When you're doing a surgery through the endoscope, in our case, colonoscope. That means that you need to enter from the rectum, get by the colon into the cecum, bring the appendix inside of the cecum and suture it from the inside. Never saw how it's done, don't know the technique, do not know the people who can do this, but read about that and know some people who claim that they doing this. But the method exists, officially registered. What's the name of the surgery itself?
Appendectomy.
Appendectomy, removing of the appendix. True. So when you're describing and what surgery you need to do, you're describing the method of access and the surgery name itself. In our case, the golden standard, like I said, laparoscopical appendectomy. In post-operative treatment, what should we prescribe? What kind of conservative therapy you should use?
Antibiotics.
Antibiotics, number 1. Good. What else?
IV fluids.
IV fluids, correctly. For detoxification and hydration reasons.
Analgesics.
Analgesics, correctly. Pain management. True, true. Can we prescribe pain management before we put in the diagnosis? Because the person suffers from pain.
No.
Tricky question. No, we cannot, because the painkillers will hide the clinical picture and physical examination symptoms that will make the diagnostic problematically, and all the people in our region knows about that. And not just medical stuff. Generally, all the people know that if there is pain in the abdomen, you do not use analgesics. Okay, what else we should prescribe?
Rest, not physical activity.
Absence of physical activity, correctly. That's true. For how long, actually, in details, if you say? There is rules that you only the first couple hours after surgery, like from 12 to 24 hours, you're supposed to ask the person not to move a lot. preventing his shaking of the body when the postoperative region will be stabilized. After that, as much the person will move, as better for him. That will increase his healing process and regeneration process. So only first day they are resting. All other days they're supposed to move. Non-steroid anti-inflammatory drugs. That will be a good thing to prescribe as well. NSAIDs, decreasing the general amount of inflammation, keeping them in the process of regeneration. So, plus the double effect, pain management, can be done as well by NSAIDs. Another one, spasmolytics. Good thing to prescribe before the surgery and sometimes in the second day after surgery to increase the blood flow in that region, to stimulate the regeneration. And in the first stage, if the problem is the edema and squeezing, that will normalize the blood flow, better stimulate the blood flow. It will not make it adequate, but it's still better. The diet as well, you should prescribe the diet. In postoperative period, because the appendix is a part of the intestine, you need to prescribe diet number 0 for the first day. Why I told diet number 0? Because in Ukraine, we're using the 15 diet tables by Posner. 15 diet tables by Posner. Each of them have specific diagnosis, and it's describing what food you can, what food you cannot, and what food is recommended to feed during different kind of diagnosis. For acute appendicitis diet number 0, that means that the person is not supposed to eat or drink something. Absence of enteral nutrition. And that's for the first 12-24 hours of the surgery, after the surgery. After that, in the second day, you recommend him to drink only fluids, only fluid kind of food and nutrients. And the third day, you recommend him to eat only smashed food in a toothpaste consistency. It's supposed to be smashed potato. I think I told it correct. You understood me, guys. I'm asking about the English.
Yes, mashed potatoes.
Yes.
Yeah.
Smashed potatoes. Okay, so in the same consistency as smashed potatoes. That's the eating for the third day. And only after that, if the person eats, do not vomit, do not feel nausea, and he go into toilet, he can eat on the fourth day everything that he wants. So in total, to get out from this surgery, he needs 4 days of different diets. Another thing, guys, that I want to tell to you that what you need to know. In Ukraine, I told you about the rules of the hours, but it's in Ukraine. In other countries, I met different kind of protocols, different kind of orders. For example, in another country, the one that I prefer to use is the fact that they claim that appendicitis in the first stage of cirrhosis, simple inflammatory or catheteral inflammation in the first stage of inflammation can be treated medically without surgery. And that's actually true. I tested that on a different amount of friends and patients, and generally this thing works. If you're treating the appendicitis in the right way, and you're actually sure that it's the first day of the disease, you have a chance to solve it conservatively. But if you're doing that and the person doesn't feel better, second day you're supposed to do surgery, definitely. Be careful about that. What else I wanted to tell to you guys about appendicitis? The fact that you need to understand that now we talked only about teenagers and only about one diagnosis. In total, for today's topic, we're supposed to discuss 5 diagnoses for all 3 periods of pediatrics that we have. So you do imagine the amount of information that you need to read that you was supposed to read for today. The same thing for each topic, guys. Keep that in mind. Okay, what's the features of appendicitis in toddlers? In toddlers, they will have what? They are younger, they are less experienced in life, and that means that they will not be able to explain to you everything in details. Plus, they pretty often mistaking discomfort with pain, and you need to learn to differentiate that things. As well, you need to find an access to the child, because if they don't want to be palpated, they will not allow you to do that. They will struggle with you, and that will break your diagnostic technique. So in this case, focus mostly on the numbers. That's my recommendation. The temperature is in numbers, blood pressure is in numbers, laboratory results in numbers, and if you manage, test some physical examination methods. Infants in diagnostic, most complicated ones, that's the place where you need to differentiate appendicitis with every single other thing that can cause pain or discomfort for the infant, because the infant cannot even explain. He cries and shouting because of discomfort, and he have some kind of problems with diaper, or he actually feels pain because of the appendicitis. And in this case, even laboratory results will not give you clear understanding, because otitis, for example, inflammation of the internal ear, purulent one, can give you the same laboratory numbers as in case of appendicitis. In this case, guys, one sign could be present in infants, and that sign will be present even through the medical sleep. It means that when you need to diagnose the baby, infants, and he's really irritated, you can ask anesthesiologist to put him in a sleep for a couple minutes, so you can do the physical examination and you can focus on your sensation in the fingers. The sign of repulsive arm. That means that you're palpating the area of appendix that's supposed to cause pain, and the child, even through medical sleep, reacts on your palpation because it's really painful, and he tries to grab your arm and push it away from his body, protecting himself. That's an infant reflex, and it cannot be blocked by an ordinary medical sleep or a behavior of a child, ordinary one. But make sure that your arms are not cold and he's not reacting on cold. Your arms doesn't have some kind of problems with nails or something that can also bring pain or discomfort to the infant during your palpation. So be sure that you actually, it's pain but not just discomfort for the infant. That's difficult to put diagnosis of acute appendicitis in infant without additional methods of examination and ruling out of other kind of pathologies by other specialists, like ENT doctor, like stomatologist, so like pediatrics himself, internal medicine doctor for children, so, or neonatologist if the child is below 1 month. Any questions, guys?